Welcome to the Oncology Journal Club podcast, a fun and educational oncology learning resource for medical professionals. I'm your producer, Rachel Bavin, from the Oncology podcast. I'm joined by our esteemed hosts, Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. Today's episode covers an eclectic mix of papers from many different specialties. Craig tackles ASCO's non-small cell lung cancer recommendations, sarcomas in Brazil, and cardiovascular risks in patients with cancer. Kate dives into endometrial cancer, the HIMALAYA study, and CAR-T. CJ looks at colon cancer, pancreatic cancer, and pain management. And a shout out to our Series 1 hosts, Professor Eva Segelov and Professor Hans Prenen, who both have papers in today's episode. For additional insights, links to the papers and bios of our hosts, visit the show notes on oncologynetwork.com.au. The Oncology Journal Club podcast is produced with pride by the podcast team at the Oncology Network. Thanks for listening.
G'day, welcome everybody to episode 8 of the Trans-Tasman Across the Ditch OJC podcast. We've all just got our heads around all the information from ASCO. It was quite a big meeting this year, wasn't it? Probably quite a few practice-changing things, and we'll touch on that and then get into some new information. How are you going, Kate?
Very well. Beautiful day in Wellington today, as always. Poor old Craig wanted to know what the light was coming in the window.
And Chris, how are you going?
Kia ora, e hoa. Look, I'm doing really well, thanks very much. I've got myself a brand new pooch, a little wee cavoodle called Alfie. And cavoodle, of course, is an Australian brand of doggy, and I absolutely utterly love him. My first doggy ever in my entire life.
I have no idea why you brought that up, but anyway, we'll just go straight into it.
It's an important, exciting event in my life, Craig, you know? I like to share with the audience what's going on in my life. And if you do hear some barking in the background, it's for the latest podcaster.
Okay. So, Kate, what have you got for us this episode?
So I want to put a caveat on this presentation. I no longer treat gynecological cancer, but I do find it fascinating when you read papers from other people's subspecialty. You wonder how the thinking in each subspecialty is so very different. So you'll all recall that we were very excited post-ASCO and continue to be very excited about single-agent or double-agent IO in dMMR, colon, and other GI cancers. We've chosen, or the colorectal community has chosen, to not do chemo plus IO. They've chosen to do IO alone. In endometrial cancer, at least in first line, the data was all chemo plus IO. And there are stonking hazard ratios compared with chemo alone, but I feel like there's a missing arm, although all the second-line data is single-agent IO. So both the RUBY and NRGGY018, so RUBY being chemo plus dostarlimab, NRGGY018, which needs a sexier name, is chemo plus Pembro, have very similar hazard ratios in the dMMR group, and intriguing non-significant hazard ratios for both PFS for both and OS for the RUBY trial in the pMMR group. So I'm really just putting a question mark to cleverer brains than me as to why we still don't sit down as a community and talk about our findings amongst each other, and are we missing out on good strategies as a result? Thoughts?
Yeah, you're talking then about the issue of super subspecialization versus general medical oncology. I think that's right, Kate. I think you see when you're coming across, feasibilities or discussions about new protocols in a certain tumor type, being in regional and being involved with more than one tumor type, you can see that sometimes perhaps the lessons learned from one tumor is not necessarily translated across, and that's probably the important role of medical liaisons within pharma companies and people within non-pharma cooperative groups to transfer that knowledge. So as you say, in colorectal space, single agent IO has been shown to be pretty effective in early studies with not long follow-up. So it's intriguing that in the endometrial space it's gone with combination chemo rather than just single agent IO. Yeah. So it's a good comment and good hypothesis. So maybe it's almost a standalone specialty, isn't it now, gynae? maybe that's one of the issues there.
I am curious. I'm curious particularly and I know as a GI oncologist, I don't think Capox is particularly toxic, provided you watch the oxaliplatin. But carboplatin paclitaxel comes with peripheral neuropathy, needing a lot of pre-meds, alopecia, Chris is raising his eyebrows, in a group that are all, and it is a disease of the older and the infirm. So I'm curious as to why there isn't a third arm in those trials, and there may be some biological rationale, but it is not discussed in any of the papers that I've read, and I am just really curious. So if there are some gynae oncologists who know more about this stuff than me, I'd love to have it explained to me. I'd also like to understand whether the signal that we're seeing in endometrial cancer is driven by another biomarker we haven't picked out yet. In the pMMR groups, they are getting responses that we do not see in other disease types. Although there are POL mutations in endometrial cancer, my endometrial cancer colleagues reassure me that the chances of those going to stage 4 is very low because they do so well. So I'm fascinated.
Okay. So, Kate, you said something intriguing there about Capox was not toxic or something. So that looks like a segue, actually. That's a set.
Oh, yes.
Going into now Chris's paper, which is about oxalic-based adjuvant chemotherapy in older patients with stage 3 colon cancer. So let's hear what Chris has to say about Capox.
Just choking on something there, thinking that Kate's saying that Capox isn't a toxic regime. I think you should ask our charge nurse on our ward if Capox is a toxic regime, and she'd probably say yes, based on the length of stay that people have on TPN from that combination. Nonetheless, the long bite I wanted to talk about today was oxaliplatin stage 3 colon cancer, an analysis from the Accent IDEA pooled database from the 12 trials. Of course, Accent was the brainchild of the late, great Dan Sargent, who had visited AGITG Australia a number of times. Was a great servant to the GI community and is sadly missed. IDEA and Accent, people will remember, was an international collaboration where they analysed 12 adjuvant studies of 6 months versus 3 of oxaliplatin-based fluoropyrimidine-based chemotherapy in stages 2 and 3, predominantly colon, but also occasionally rectal cancer. The headline from that study was that effectively 3 months versus 6 was about the same. Maybe in the high-risk groups it was 1.4% difference, but 30% more toxic for 6 months oxaliplatin-based therapy. There's been this big question mark, though, hanging over patients aged over 70 years of age with oxaliplatin. If you look back at the original Mosaic study and even the NSABP CO7 study, which was bolus 5FU versus bolus 5FU with oxaliplatin, when you looked at the subgroups, those over 70 never actually had a significant survival gain from oxaliplatin at all. Their time to relapse was about the same, but their overall survival was shorter in the over 70 age group. So the question of whether actually oxaliplatin adds anything in the over 70s has actually been a bit of an open question. If you're an evidence-based stickler, you would say there is no evidence for benefit of oxaliplatin in the over 70-year-olds. But most people would still use oxaliplatin in stage 3 colon cancer still, as I say, actually without strict evidence. Also, the other thing is that oxaliplatin doesn't actually add all that much, despite the fact that it is standard of care in stage 3 colon cancer. The DFS gain is good, 5 to 8%. That's a good additional gain, but the overall survival gain in Mosaic is only actually 4%, so it's actually quite limited. And given it can cause up to 30% neurotoxicity grade 3 at 6 months, it's very relevant to shorten the course. So why might the over 70s be a different subgroup? Well, over 70 you get age-related immunosenescence, and age over 70, oxaliplatin is an immunomodulatory agent as much as it is a DNA double-strand breaker, so that might be a mechanism. Patients over 70 may have increased toxicity due to changes in distribution of body fat and changes in sarcopenia. And of course, people over 70 may have additional comorbidity or frailty that's not there in those under 70. Now, when the average age of diagnosis of colon cancer is 67, this is actually a really important question for the majority of people with bowel cancer. So that's a preamble. Onto the study. This is a pooled analysis looking at differences in toxicity and outcome data in those aged younger or older than 70. 12 studies, more than 17,000 patients, the largest cohort we've actually got. They looked at does dose intensity actually partly explain the lack of efficacy, and is dose intensity different between those groups? The 3 key endpoints they were looking at were time to relapse, which was the time from randomization to relapse, and if you died of something other than colon cancer, that didn't count. DFS, which was recurrence or death. So if you had a toxic death, that would count, and overall survival. And they looked at the early treatment discontinuation and early oxaliplatin discontinuation between two arms and overall grade 3 for toxicity. What they found was those patients aged over 70 were more likely to discontinue oxaliplatin chemotherapy or all chemotherapy prior to receiving 75%. So over 70s had 22% discontinued early compared to 15% under 70. And oxaliplatin was discontinued early in 42% of those aged over 70 compared to 33% of those aged under 70. The relative dose intensity was about 7% lower in those over 70 compared to those under 70. So those are actually quite interesting margins in terms of exposure to that. In terms of toxicity, there wasn't any major difference except for grade 3 diarrhea. And grade 3 diarrhea is more than 7 loose motions a day requiring intravenous fluid. And usually when you get that with capecitabine, you're in hospital for 1 week, 2 weeks, sometimes with TPN. Occasionally, you've had patients with toxic mega who need major surgery. It is a debilitating complication, grade 3 diarrhea, in people with capecitabine. And it goes from 11% to 14%, which is meaningful. It's the difference between 1 in 10 versus 1 in 6. In terms of efficacy outcomes, well, it's not an oxaliplatin versus not study, but what it did show was that even though the time to recurrence was no difference in those under 70 and over 70, the overall survival and DFS was 7% worse if you were aged over 70. So our older patients are doing worse. They are getting a little bit less chemotherapy, but the chemotherapy toxicity profiles are broadly similar. It does not necessarily explain the differences in overall survival. And whilst it provides some toxicity reassurance, I still don't think it's put to bed the question of whether we should be giving oxaliplatin routinely to those aged over 70. So I think it remains a legitimate discussion, 6 months capecitabine alone versus 3 months Carepox for those over 70. And evidence-based sticklers will say no real evidence for oxaliplatin in that group, and I think that's true. Whereas I think it will remain standard practice for many around the motu or around the country, around the land, to continue to give that, even with questionable evidence. So there we are. What do you think, Craig? Have I convinced you to reconsider oxaliplatin in your next 75-year-old with stage 3 colon cancer?
Well, it's difficult, isn't it? So is it age or is it the function? So again, we screen all our patients with a G8 score. We're still stuck in this kind of age mindset.
Is that because you're getting closer to that age cut point, Craig, so you want to be considered an individual?
Possibly.
But, you know, whereas Kate and me, being at least a generation younger, aren't so caught up on that.
But, you know, that's an interesting question, isn't it? So it's, I think everybody would give pause to using it in the over 70. They need to be pretty fit, and probably 75 is probably really stretching it. So, but your DFS-OS argument's interesting. There was a landmark analysis by the FDA many years ago showing that 3-year disease-free survival was in fact a reasonable surrogate for overall survival, because, you know, sometimes we can't wait for the 5-year overall survival to start making decisions. So, and there is that element of crossover, or people not actually getting the drug when they relapse. So you need to give your best drugs first. So I would think that the landmark mosaic data still provides the standard of care for at least the under 70s anyway.
Yeah, look, I think that's right. And I think this paper still holds up the DFS and OS relationship. But the time to relapse is different to DFS. The time to relapse is only from diagnosis to relapse cancer, and it excludes death from any cause. So as you get older, you get competing causes of death, right? So competing morbidity, competing mortality. So you might die of cardiovascular death, you might die of, anything else. But actually, it's entirely plausible that oxaliplatin or other therapies actually accelerate cardiovascular risks. It's entirely plausible. So I don't think you should discount, DFS or OS as the endpoints in favour of time to recurrence. So I don't like time to recurrence because it excludes all causes of death. I do think you have to consider competing morbidity, competing mortality, particularly in adjuvant populations, because it is relevant whether or not it might accelerate some other risk factors. So DFS, yep, I'll take that in an oxaliplatin colon cancer study every day of the week. It's been a well-proven surrogate, not true for other diseases, but OS for adjuvant and other studies still remains the king. Long live the king.
Kate, would you agree?
I do agree to some extent. I think this is where the art of oncology kicks in, because I think what Craig was alluding to is there are 45-year-olds and there are 75-year-olds, and some 75-year-olds look 45 and are physiologically close to 45, though I always tell them that even though they look good, their liver and their kidney are probably a bit tired. But there are, I think it's interesting. I sat in a room where we were presented some cases that looked different on the surface, but were actually very similar. They gave us 5 in a row, and all they did was change the order of the clinical information and then change the age subtly to try and figure out where people's comfort is. People are increasingly comfortable with treating people under 75 as young people. Treating people between 75 and 79 is kind of a bias, but as soon as you hit 80, people are like, well. So I find that really interesting, and that's just a gut thing. That's because there is no data in what to do with people over 80. But Chris is right, an increasing number of our patients are properly old, at least on paper. Yeah, and we have no data as much to do with them.
Yeah, I think that's right, Kate. When you look at the differences between jurisdictions and projects like the International Cancer Benchmarking Project, which is comparing outcomes between high-income countries, some of the real differences in cancer stats are happening in that 75 plus, 80 plus age group. So there are some countries which are treating that geriatric population more aggressively. And so how the patients in that age group get treated in New Zealand may be different to how they are elsewhere. Patients are important to keep at the centre of everything, but there are some inevitable things that happen as you age, including, as you point out, renal function. Capecitabine is a renally cleared drug, of course, polypharmacy, and I think changes in body composition are actually quite relevant. People often assume that obese patients get more toxicity because they get higher dosing, but that's not true. It's the inverse. People of low body weight actually get higher toxicity, and I think that probably is sarcopenia, which does that, right?
Yeah, look, there are some really, really simple interventions that we keep forgetting, which is that the more physically active our patients are while on adjuvant chemotherapy, the better they do, both tolerance-wise and disease-free survival-wise, and we forget. So, I am delighted that we're getting some ridiculous amount of money to spend on new drugs, but we don't have outpatient physio. And so, that's my little plug for my personal bias.
Yeah, I think that's right. Everyone should do CrossFit.
Or just go for a walk. You don't have to join a cult.
All right. I've got a few quick bites and a medium bite. So the first thing to mention is management of stage 3 non-small cell lung cancer, ASCO rapid recommendation update, published in the JCO in June. So in 2021, ASCO published their guidelines for stage 3 non-small cell lung cancer management. And then 2023, they issued a rapid update, and they've done another one on the basis of the phase 3 LAURA trial, which was presented at the ASCO meeting. It was one of the kind of much discussed and landmarked meetings that we talked about in our ASCO update podcast. This was a study where we joked about you could drive a truck through the survival curves, or the PFS curves, should say. So this is a study in patients with stage 3 disease following concurrent or sequential chemoradiotherapy with a EGFR exon 19 deletion or an L858R mutation, 2-to-1 randomization, oral osimertinib 80 milligrams once daily or placebo, and there's only 20% surety for the overall survival data, but the PFS survival data was 39.1 months versus 5.6 months with a hazard ratio of 0.16. I didn't mispronounce that, 0.16. And so on the basis of that, ASCO has gone ahead and recommended that that should be the standard of care for those patients. My next one is a paper from Brazil in the JCO Global. And so this is a discordance between the initial diagnosis of sarcomas and subsequent histopathological revision and molecular analyses in a sarcoma reference center in Brazil. And so in nearly 60% of cases, the initial sarcoma diagnosis was modified when it was revised by a reference center and dedicated pathologist assisted by molecular pathology. So sometimes it changed from malignant to benign, or the subcategorization of the sarcoma was changed. So interestingly, that was consistent with other data from Europe and North America as well. I think I just wanted to highlight that because I think it reflects probably contemporaneous practice in that people are referring sarcoma cases to a reference centre, and if they're not, they should. And it probably highlights that we need to continue to do some work in other less common cancers to really have some reference centres where at least pathology can be checked or MDT discussion can be held remotely, and then components of care are delivered closer to home. But I do look at the JCO Global from time to time, and Eva Segelov, our former host, is an editor of that journal, and they do have some interesting articles from lower and middle income countries. And then another one I know you're going to do some pancreas cancer short bites, Chris, but I found one, pancreatic cancer surveillance and survival of high-risk individuals. So this was a comparative cohort study, not a randomized study. Patients with high risk, so these were people with a strong family history or a known genetic mutation predisposing them to developing pancreatic ductal cancer. But they were this was matched controls where they were given surveillance versus previous controls. And they actually demonstrated at 5 years a lower mortality rate in the high-risk individuals compared to the controls of 43% versus 86%. And the high-risk patients live longer than the matched controls with a median overall survival of 61 months versus 8 months. And the 5-year overall survival rate, 50% versus 9%. So it's an interesting study. Kate or Chris, in your practice, in your centres, would high-risk individuals be undergoing surveillance for pancreas cancer?
No. I'm curious as to what the surveillance methods were.
They were some ultrasounds.
It was endoscopic ultrasound and MRI, wasn't it, Craig?
Just looking at the detail, it looks like they got either CT or MRI or endoscopic ultrasound. So it looked like it varied between institutions. It was done across 8 sites.
You know, when the alternative is a Whipple for many of these families, if they really want to reduce their risk, then it's easier to justify heavy surveillance. But I'm curious as to anybody is offering an age-related, age-specified Whipple as a third option. So you've got your don't do anything, survey very heavily, and would anybody put their hands up? Some of these families have almost a guaranteed risk of pancreatic cancer, disgusting disease that it is.
Yeah, look, I mean, I think people who've got familial cancer syndromes or very high-risk cancer are very interested in this, you know. And I think the way in which MRI is going in particular, looking at whole-body MR2, you can actually do screening for multiple sites all at once. So there are a lot of advances there. I'm not sure that standard CT and this would be an awesome idea. And people have already got DNA repair problems exposed to ionising radiation. So I think you don't really want to do that with non-ionising techniques like MRI or alternatively with EUS. And EUS is not non-morbid, but I think if you're looking at people with BRCA1, BRCA2, they could be highly, highly motivated individuals to undergo this type of screening.
Great.
Yeah, I was talking more at the higher end, and that BRCA1 and BRCA2 have a significant risk, but there are other familial syndromes that their pancreatic cancer risk is the relative risk is 88 times the baseline risk. You know, we're talking ridiculous. I think it is really difficult in New Zealand practice to get young patients with pancreatic cancer to see genetics in a way that it's not tricky to get young patients with breast cancer or ovarian cancer to see genetics, even though we know that the pickup for people, even without a family history with pancreatic cancer for somatic genetic mutations is very high, much higher than a young triple-negative breast cancer woman, for example. And there's definitely some work to be done advocating for more equitable access to genetic screening.
So, Chris, you've got a couple of short bites.
Yeah, well, staying with the pancreas theme a little bit longer there, Craig. A real problem in the management of people with advanced pancreatic cancer, of course, is celiac plexus nerve pain, which is a really troubling and debilitating symptom for many. People end up on opiates, on neurolytic agents like gabapentin, membrane stabilizing agents like gabapentin or pregabalin, for example, and it can be really difficult to control that. You have access to celiac plexus neurolysis in many centres, particularly using EUS. And some people argue for two-directional EUS with neurolysis versus one. But like most of these palliative measures, the evidence basis for the intervention is actually quite poor, and the randomised data is not very good. I just wanted to highlight celiac plexus radiosurgery for pain management in advanced cancer, which had celiac plexus type pain. The things I liked about the study were that they used a standardized pain score in all of these patients. And they said in advance what a clinically meaningful reduction in pain score would be. They then did stereotactic radiotherapy or radiosurgery to the celiac plexus area, and they found a 53% reduction in pain by the pre-specified meaningful level, which is good to see palliative care type studies giving these types of standardised response scores. I think that if you looked at the same sort of data in bone metastases and used a similar pain score, you get a similar sort of response. So I think what you can say is that radiation to celiac plexus does give a similar level of benefit to that at which you would expect for bone mets. Whether it's better than celiac plexus neurolysis remains an open question, but it may not be as difficult to get in some areas compared to others, and so accessibility remains an issue for many of these areas. But I think it does give us some comfort that it's a good thing to do, or a reasonable thing to do, with an adverse event profile which is fairly similar to that what you'd expect in upper GI patients. The other quick bite I've got today for you guys is really just an ode to our former presenter, Professor Hans Prenen, world famous for his predilection for papers in Nature and Nature Medicine. You always just like to do that. Anyway, Hans, I hope you're listening, man. This is a shout out just for you. We miss you.
Hang on, we've got a special shout out, Chris, because we have a special segment called Blow Your Own Trumpet. Do-do-do-do. So this could be a blow your own trumpet from far away.
Well, we might have to get Hans on to answer some questions about this. I don't know if I'm blowing his trumpet particularly. I might be sticking a sock in the end of the cornet, but you haven't heard what I have to say just yet. Here we go. Hans, if you're listening in Belgium, we're going to find out. Waiting for the hate mail to come in. Anyway, this was a multi-centre single-arm phase 1B/2 study of combining a CD40 agonist with modified FOLFIRINOX. Now, Hans, did I get this right? Am I going to pronounce the drug name right? Metazolimab. CD40 agonist. Why CD40? Well, apparently CD40 is a co-stimulatory receptor expressed on the surface of B cells, monocytes, macrophages, and dendritic cells, and the CD40 agonist-mediated stimulation redirects tumor-infiltrated lymphocytes from M2 to M1 phenotype, which is supposed to help the immunoreactivity and helps immunogenic cell death. They did a phase 1B/2 study, gave them FOLFIRINOX plus a dose-finding study of this novel agent, and if they got a response rate more than 35%, they said it was successful. They achieved the pre-specified response rate of greater than 35%, and they said it was successful. Please go to a randomized phase 3 study, they say. Hans, man, response rate in pancreas cancer of 35%. Your response rate with FOLFIRINOX is 31% in multinational phase 3. So it's a pretty low bar. And single-arm phase 1B/2 studies, they don't tell us anything about efficacy. Man, I'm not into this design at all. Come back on the show. Defend your study.
We might have to get him back in metazolimab, and it's a CD40 agonistic IgG1 antibody.
That's it.
Wow.
It's a metazolimab.
So not impressed with the activity.
Even though Hans is a dear friend of the show, I'm not a fan of single-arm phase 1B studies with response rate as their primary endpoint because they are super-selected patient populations, and response rate drops as you go from phase 1 to phase 2 to phase 3. And so going straight from a phase 1 to a phase 3 with this level of data, I think will be an expensive fishing trip. So Hans, randomise phase 2 first, please, before you go to the phase 3.
Okay. Thank you, Chris. I'm just waiting for the phone to ring now from Hans. Kate, you got a couple of quick bites for us.
Yeah, just very quick. My first one is just a 4-year OS update from HIMALAYA. So HIMALAYA, beautifully named, don't know what it stands for, is the STRIDE versus Durva versus sorafenib in HCC. Remembering that these are very well hepatocellular carcinoma patients. They all have to be Child's Pew A. They got 1 dose of tremelimumab and then ongoing Durva. And although there was a Durva single agent arm, everything was powered to compare with the sorafenib arm. And the STRIDE regimen, as it calls itself, single tremelimumab and ongoing, I can't remember the actual word, durvalumab, did much better. And the 4-year OS is 25% versus only 10% in the sorafenib arm. So that's pretty exciting. And they're going to do some work as to whom is most likely to be in that 25% so that we can have a think about it. Because that's quite a cheap strategy compared with other ones where you keep going on the anti-CTLA-4 for ages.
Kate, where would you put this regimen, though, the tremelimumab, durvalumab compared to, say, IO and a TKI together?
So standard of care, quote unquote, is probably IO versus an anti-VEGF agent. Tezo-Bev published first. But nobody's done a head-to-head of IO and some kind of anti-VEGF, including TKI in that group, versus this one. And I think that there's some advantages to not having an anti-VEGF agent in that you, by virtue of having cirrhosis, many of these patients have clot, have varices, have other things that take them out of an anti-VEGF arm. I'd love to have access to this, and I think you'd probably choose horses for courses.
Okay, thank you. And then you've got a CAR T cell.
Oh, look, this is my last one. So Rob Winecove is a mate, lives down the road. And this is just a shout out to the fact that even in little old New Zealand, real research is possible if you are, and I hope Rob's listening, bloody minded enough. So Rob has managed to do a phase 1, first in human, CAR T cell in Wellington. But just so you understand who, he's amazing. So understand who Rob is. Rob was having a conversation with a mate about how it's fastest to go between the hospital and the university. And so he did a multi-visit, randomized controlled trial amongst himself. So he rode in a bike, he went in a bus, and he drove in a car. And did it door to door to try and eliminate as many confounds as possible. The guy's just a born scientist. It's fastest to cycle in Wellington. So there you go. So this was a CAR T. This is the phase 1. They're moving on to a phase 2. They want another 60 patients. And in B-cell lymphomas, relapsed or refractory, that's very hard to say, pre my glass of wine. Fantastically, for a New Zealand study, 20% Māori participants, which is wonderful, and some fantastic responses, including many sustained complete responses. So we're very excited by having this here. We're very excited by Rob driving this, and I'm also very excited to see some of the young people that he's worked with, including other local consultants and other advanced trainees listed as significant authors on this paper. So, yay, Rob. Way to go.
And have you talked to him, Kate? Like, where's this going? You think it's going to... I mean, CAR T cells seems to be coming into play more and more in the relapsed refractory non-Hodgkin's lymphoma. And is that what they expect with this particular version?
Yeah, look, I think he's been really clever. So one of the things that he's trying to do at the same time is capacity build. So he's been building in an understanding of the toxicity reviews that require. So he has a relationship with neurology, he has a relationship with ICU, he has a relationship with our drug funding organisation in terms of tocilizumab. You know, he's really been thinking about that. How do we make this into a CAR T program that New Zealand can sustain internally? So, I think at the moment, relapsed refractory lymphoma, moving into a larger group of patients, confirming his responses, but he's working with the Mulligan, which means that he has the control over the genetic design. So as we find more targets, he will be able to adapt these T cells to attack those targets. So really exciting.
Is there a CAR T cell program anywhere in New Zealand?
No, this is it.
Yeah, wow. So it's interesting because I learned today that the 6th program has opened in Australia in Townsville. That's a big university, comprehensive university hospital with most components of, oncological surgery, etc. But they've just started a nascent CAR T cell program there to enable access for patients in North Queensland. So, which I don't know, 3 million people in New Zealand. There's probably 1.5 million people in North Queensland. Hopefully, a program will come up in New Zealand, but it's presumed at the moment people cross the Tasman if they need to access this, but it'll be very expensive for them.
The most famous patient here who has been incredible, and I apologise if anybody's listening can remember his name, it's a comedian. He went to the States to join a research program with his own lymphoma, raised a lot of money. By the time he got over there, he got accepted onto a trial, didn't need the money. He donated all the money to the Mulligan to help set this up. So this is a beautiful story, and at some point the book will be written.
Okay, fantastic. And then my last paper is another blow your own trumpet from afar, because one of the authors, Eva Segelov, who is now based at the University Hospital, University of Bern in Switzerland, and she co-authored this with Sean Tan from the Victorian Heart Institute in Monash, and the senior author was Stephen Nichols, also from Monash, who we've had on the show. Eva did a whole podcast on cardio-oncology, and I refer people back to that. We'll put a link in the show. It's still an interesting topic and we're thinking about. So this paper was in a journal called European Journal of Preventative Cardiology, which is the journal of the European Society of Cardiology, and it's called Cardiovascular Risk in Cancer Patients Treated with Immune Checkpoint Inhibitors, Challenges and Future Directions. So it's a bit of a review, but authors making the point that as people are living longer with cancer, especially after the advent of immune checkpoint inhibitors in certain tumours, they're being put more at risk of cardiovascular events. So they actually stated that, there's a growing body of evidence around the risk factors for people receiving immunotherapy. And so the atherosclerotic cardiovascular disease, there's some evidence from a retrospective study of 6,000 patients of a threefold increase in myocardial infarction and stroke following immune checkpoint inhibitor therapy. So that's, quite a lot, threefold. So we know about myocarditis as a sort of acute onset, but because these are pro-inflammatory agents, so it sort of makes sense. We've known for a long time that there's a link between chronic inflammation, cardiovascular risk. And so they're making the point that, like with many other cancer treatments, we need to think about testing people for cardiovascular risk factors and managing that. And of course, we start getting into the space of, do they have advanced disease and they're not going to do well? Do we need to think about cardiovascular risk factors? But now we're actually curing people, or people are living for years. Whose responsibility is that? Is it everybody's responsibility? Is it medical oncologists? Is it the GP? Do we need to set up clinics, refer to cardiology service? There's evidence as well as that atherosclerotic risk that it causes dyslipidemia. So there's a growing body of evidence. So we won't get too much into the discussion, but I think it was just something for people to note that and think about, as we having put more and more people surviving their cancers or living longer with their cancers, we do need to think about the whole person and thinking about those other risks that we might be exacerbating. So interesting paper.
Yeah, I wonder if we're going to, as adult oncologists or oncologists of adult patients, need to learn from the survivorship clinics that come out of pediatric cancer. We've had the luxury or the lack of luxury of not having a lot of long-term survivors, and now we're in another space.
Yeah. Kate, there's a service improvement project grant application there. So it's, I think it's this paper points out there's a whole lot more population-based research needs to go on and researching new models of care, etc. So I think going forward, we're going to see more and more attention in this space. So I thought it was worth the obscure journal for oncologists, but, a topic worth noting and worth thinking about.
Thanks for that, Craig.
All right. So on that note, we will bid you all adieu. Thank you to everybody listening. Thanks, Kate. Thanks, Chris. And thanks, Rachel, on the sound desk there.
It's a pleasure.
And thanks, Kate. I will see you all soon.
Matewa.
Thanks, Craig. Thank you for tuning in to the Oncology Journal Club podcast, proudly brought to you by the Oncology Podcast, part of the Oncology Network. For healthcare professionals seeking regular news updates and insightful discussions, we invite you to join our community at oncologynetwork.com.au. Your free registration includes a complimentary subscription to our weekly publication, the Oncology Newsletter, a valuable resource to stay updated on the latest advancements in the field. We value your input and welcome your feedback and paper recommendations via our social media channels, email and website. Your insights help shape the conversation and drive the direction of future episodes. This is Rachel Babin signing off for the Oncology Journal Club podcast.